So I was asked to talk about a few of our cases that we have had over the years in advanced heart failure, specifically with the minds that this would be kind of a discussion with some of the advanced heart failure doctors that were here to present as well. So I'm going to talk through two different patients that I've taken care of over the past 3 years. One exceedingly young, one exceedingly old, both highlighting different aspects in the struggles we have with decision making in heart failure. So I titled this talk The Good, the Bad, and the Ugly. One of my favorite movies, Spaghetti Western. You guys will learn a little bit about it as we go through this. But one of my favorite quotes is that there are two kind of spurs, my friend, those that come by the door and those that come by the window. And heart failure is one of those things that sometimes comes at you straightforwardly, sometimes from the side. I don't really have a clicker. So financial disclosures, no significant financial disclosures. These are my two kids. They're exceedingly cute. Next slide. The objective of this talk is really to discuss the process of medical decision-making in the setting of real-life cases that are exceedingly complex. So the first case, let's talk about real-world situations that come up in the heart failure clinic. So we have a 28-year-old female, mother of two, history of depression and ADHD, sertraline, no other meds at the time of presentation. Approximately 1 month after her second childbirth in February of 2022, she had increasing dyspnea and fatigue, right upper quadrant pain, dry heaves, and decreased appetite, for which she was seen at her local ER and eventually treated for bronchitis for what was labeled as some sort of upper respiratory infection, and eventually developed some bilateral leg swelling. So May of that year, things hadn't really gotten any better. She'd seen her primary doctor, was eventually sent to San Juan in Farmington for worsening shortness of breath, dyspnea, with very minimal exertion, and found to have severe heart failure, AKI, and a congestive hepatopathy. Her EF at that time was 16%. And so one of the first things for this first case is really highlighting the difficulty of shared care in advanced heart failure patients in a state that is very rural, meaning our resources, as you get further and further away from density or population densities, gets less and less as far as what you can do. And so one of the ways that we try to do the best care for our patients in the state is to couple and kind of work with larger centers. And so this is a case that highlights how that happens and how that happens well in a younger patient. So a little later, she was transferred to the heart hospital. We diagnosed her with a peripartum cardiomyopathy as well as cardiogenic shock. On arrival, her cardiac index was 1.4, her RA pressure was 16, and she had a wedge of 25. At that time, we placed a swan. She was started on milrinone and diuresed with IV Lasix. Over the next few days, 4 to 7 days, probably more like what happened, is unable to wean the milrinone. She had drastic improvement in her filling pressures, but ultimately we decided that with her degree of heart failure, we should probably send her to a larger institution to decide about trying to wean the milrinone further or pursuing advanced options. Next slide. So whenever I uploaded my slides, it's having to be done via a remote access, so I don't actually have the clicker. Can you go to the next slide? Okay. So essentially, she was transferred to the University of Utah, where they agreed that she was excessively sick. She had a continued low cardiac index. They decided to pursue a medical therapy option where they started digoxin. At that time, she also had an echo that showed a new LV thrombus, for which she had right MCA stroke. Didn't get TPA, had resolution of her symptoms within 48 hours. And after starting digoxin, they started to slowly wean her milrinone. She had kind of acceptable cardiac index. She had no end organ damage at that time, was still kind of that walking wounded, walking shock, only getting by her reserve being so young, but opted to try start her on small doses of goal-directed medical therapy and bring her back relatively soon for a follow-up. And so I talked to their clinic at that time. They had referred her to see me in clinic 4 weeks after that discharge. If anyone knows the geography, Farmington, 3.5, 4 hours from here, about 8 hours, maybe 6, 5 hours from Salt Lake City, but we were marginally closer than the largest center next to us. She was discharged, I think, on dapagliflozin and just a little whiff of spironolactone, like 12.5. She had normal kidney function at that time. About 4 weeks later, she was set up to see me in clinic. She no-showed that appointment, which prompted me to call her when she said, "Oh, I'm actually admitted back in Farmington for heart failure. I've been here for 3 or 4 days. I'm volume overloaded." And essentially, that prompted me to call Utah and say, "Hey, this lady's not doing well. She lasted all of 3.5 weeks outside of the hospital." And so that prompted them to reach out to San Juan and actually get her transferred back up to Utah for a repeat evaluation for advanced options. On presentation, she had a cardiac index, I think, of 1.2, relatively normal filling pressures, and required repeat inotropes and pretty much cessation of her goal-directed medical therapy. Was initially in a shock state with an AKI that had resolved. And initially, the decision for the team in Utah at that time was really to discuss, is she an advanced options candidate? And if so, obviously she is. What do we do first? And I think in advanced heart failure, this question is very difficult. It speaks a little bit to what Dr. Binyars was discussing with the timing of valves and the timeline. And this is a contentious topic. Do you go with a transplant first approach? So it's the slide after this one. A transplant first approach, or do you consider putting in maybe an LVAD in the hopes that you could give her more time and then either bridge her to an eventual transplant or bridge her even to recovery where you explant the LVAD and see what to do next? And I think the burden there is really what does the data say? And a lot of the times we don't have high level data to discuss that. If you look at the ISHLT registry that was last published in 2018, you see that in her age group, the median survival is around 13 to 14 years. And when you're in your 20s, you don't want to be told 13 to 14 years. The opposite of that is 50% live much longer than 13 or 14 years. And so whenever you're discussing with a patient the risk and benefits of what you should do, it's really a lack of data of should we go with this approach first, knowing that the only other option after a first transplant is a second transplant? Or do we even consider doing a different approach in the hopes that something else will change or that we can change or shift that timeline further down the road? And so University of Utah came up with this scoring called an ICARS score. I don't know if you can advance the slides to where I'm at, but so 2 options, direct transplant or bridge to recovery or bridge to transplant. So one after this. So this is the ISHLT data that I referenced, and then this is the ICARS score from the University of Utah. And whenever you run her numbers, she had a relatively high chance of recovery, somewhere around 40% after an LVAD, leading to a possible explantation. And so can you go forward? And so this is her risk of recovery here. And so this data is limited. It comes from something called the VAD-WEAN registry, where they look at patients of varying ages to see how they do, to see if they are explantable back to their native tissue, or if they would require then a subsequent transplant. And if you ask anyone in the field of advanced heart failure, it's a very difficult conversation with a patient because of how organ allocation works in today, which is in 2024. If you're going for a transplant first strategy, it really benefits the patient to essentially be in low-grade shock with some sort of mechanical support, and you'll be listed status 2 in most centers unless you really have refractory shock, and then you're status 1. But whenever they changed that in 2018, which is the last year we have the data for survival, that question became difficult to answer because it really, in a good-hearted way, not meaning to make any big changes, disincentivized LVAD as an upfront approach. Because if you're stable with your LVAD, you're status 4, which essentially means you're probably not getting a transplant unless you have the right blood type or certain other situations in your actual UNOS zone. And so this becomes a very difficult conversation to talk about, because clearly the quality of life with a transplant compared to an LVAD is substantially better if you're getting transplanted. You don't have to worry about batteries. You don't have to worry about Coumadin. You don't have to worry about carrying around all the equipment. You don't have to worry about a lot of other things that with transplant, although it's a kind of a shift in what you're doing or what you're focusing on, the quality of life is a lot better. So most patients, if you say LVAD and then eventual transplant, they'll say, let's just do the transplant first. Like, why would I fly to St. Louis to get to Nashville? Why 2 stops? Why an extra surgery? And in some scenarios, the idea of organ allocation and it being a limited non-renewable resource is a big deal, because you can expand the donor pool by reducing the amount of people who need a heart. And so if there are certain patients you think are relatively possible that they would recover their heart after a certain amount of years on LVAD, and you could explant them to their native heart, you are essentially increasing the donor pool for everyone. And so to the next slide, please. So she had a high probability of recovery. And so working with Utah, they said, let's do an LVAD as either a bridge to transplant or recovery and then eventual explant. And that only works in a scenario where the actual explanting center has the ability to trust the person on the other side of the line, meaning shared care here is huge, both for our patients, because New Mexico itself doesn't have a transplant center. And so what we can offer her is relatively limited. But what I could offer is I could see her soon, I could up-titrate her meds, and I could essentially say, yeah, she's doing everything we've asked her to do. If she's actually recovered, she'd be a good candidate for either explant or a transplant when her LVAD becomes a problem. And so for those in the room who kind of are unfamiliar with an LVAD, these are the essential parts of the HeartMate 3, the only commercially available LVAD on the market currently. And essentially on the left there, that picture, you have the actual pump itself coming out of the apex of the left ventricle. Then you have an outflow graft that goes up to the aorta. And then that wire coming down and then kind of out of the abdomen is called a drive line, and that's essentially the power line for the actual pump. And it goes to a controller, which is essentially the brain, and that controller has 2 batteries coming off of it. And so the controller tells the pump how fast to go. It also gets feedback from the pump and how much blood is flowing through the circuit, what's the resistance in the circuits, what's the pulsatility of the patient. And then a lot of the dynamics of this actual pump is essentially made better by the fact that it has these magnetically levitated rotor, which is there is no mechanical part that's going to wear down over time. And so the pump itself has gotten better, but just before we go further, just a brief overview of what an LVAD is and what it takes to put one in and a patient to live with it. So next slide. So how to manage and monitor potential recovery candidates. And so the first and probably the foundation of anything you're going to do is optimizing their GDMT. So trying to getting them on the highest dose of the best meds that they can be on, so that over the next 6 to 12 to 18 months, they have a chance of recovery. You're offloading their heart in addition to the offloading you're doing with the pump. So next slide. And so what we decided to do is echo. You do an echo at 1 month and then every 3 months. And then essentially, essentially you come to a point in the line where you decide we're going to actually do an explant evaluation by essentially loading the heart and turning down the speed to see what the LV does whenever you actually let it try to pump more than the pump itself is flowing. And so she had her LVAD implant. 3 weeks later, she was discharged. At the time of discharge, she was on just dapagliflozin and a little bit of spironolactone. And we did this shared care approach. And so the goal here is to get a beta blocker, get Entresto, and try to up-titrate all those things. And in this scenario, we kind of really like digoxin in a younger patient with normal kidneys to try to allow for more room for GDMT. And then, as I said, the echoes are in those timelines. And so the question becomes, when do you actually do a loading study and bring her to a larger center to decide when to explant her heart? So young mom, has a husband who works, has a grandmother, and has 2 kids at home. And so when to travel up to actually get meaningful information for her is a big deal, because it means taking substantially more time off of work for her husband, for someone to watch kids, and coming to Albuquerque is easier. So this decision of when to go is a big part of this process for her. And so essentially, whenever her echo locally showed that with the LVAD at her current speed setting was at least 45% or greater, that would prompt then a further evaluation for a loading study. And so eventually we sent her back up to Utah to do a more invasive study where they turned down the speed of her LVAD. You can go further. And so this is their, if you go back one actually. So this is the protocol that Utah uses, that once they reach 45%, they want to turn down your pump speed to at least 8,000. So normal HeartMate 3s, they're at a revolutions per minute of anywhere from 9,000, 5,000 to 6,000. And whenever you actually turn down the pump, you're actually loading the heart. And so usually you want to get around 4,000 whenever you're turning down the pump speed for these. And they do that in a few different ways to kind of decide if they're ready. So they turn down the speed and then they look at an echo. They say, is the EF still 45% or greater? What did the size and dimensions of their left ventricle do? Did it dilate whenever you asked it to do more, or did it actually stay relatively small? And how small did it get? And then if that was met, then they would do essentially a right heart cath where they looked at invasive hemodynamics at the lower speed. And then they started to even turn it down even further. And so next slide. So essentially, after her pump speed was turned down, she met all these criteria. She had kind of a borderline cardiac index. I think it was down to like 2.1, 2.2. So we're right on the line of what you would want. And then she was eventually offered an explant, an LVAD explant, that was 17 months post-implant. And she did exceedingly well. And so this is a case where I think that was done back in February of last year. We have an echo at 3 months post-explant that shows that her ejection fraction without her LVAD and on pretty good medical therapy is somewhere around that 45% range. And once he gets that pulled back up, I'll show you just the 2 different echo pictures so you can see the difference in what her EF was prior to her LVAD. And once the LVAD was taken out, what it was like. And I think that actual picture is pretty important to look at. I don't really know what's going on with the tech. Okay. So these are the actual parameters around the time of her explant whenever they turned her down, and then you keep the swan in the ICU. Her CVP was 6, her wedge was 10, she had a PA stat of 67%, an index of 2.2, and then she proceeded with explant. And if you go to the next slide, if you can play these 2. So the one on the left is her echo just prior to LVAD implant. This is on milrinone. Actually, I have no idea which one that is. Probably we'll skip these pictures. I don't really know what to say. That's not very clear. And so the emphasis of the first case was really the importance of shared care in a market that's very rural and how that meaningfully affects patients and their outcomes. And so that's a great case of someone who's young, who is clearly very sick, who had two different roads to go down, and we picked one that was a little more difficult, and she had recovery. And, I think she's currently 2 or 3 months post explant. I saw her in clinic. She's doing great. She had walked 2 miles with her son at the zoo prior to seeing me driving down from Farmington. And so the next case is really the opposite end of the spectrum. It's an elderly patient, an 88-year-old guy who has a history of non-Hodgkin's lymphoma in remission. He also has OSA on CPAP, AFib, status post and AV node ablation, heart failure, reduced EF with a BIV. His EF is less than 20%. He also had moderate RV dysfunction, so biventricular failure. A guy who was referred to the heart failure clinic really for optimization of his heart failure, as he had had 3 heart failure admissions prior in the past 6 months, and had had frequent needs to adjust his diuretics as an outpatient with almost no success in that. And so he's a primary caretaker for his wife, who also happens to be a patient of mine. He comes to clinic with his daughter, who's a nurse, and his explicit goal is to stay out of the hospital. His CHF meds at the time that I met him was metoprolol at 100, Lasix 40 daily, and lisinopril 5. Had what some would call a normal blood pressure, but relatively high in someone who has an EF of less than 20% and a heart rate of 75%. His labs: normal kidney function, not anemic, normal sodium, normal potassium, slightly elevated pro-BNP, LFTs grossly normal other than a borderline low albumin. And so the options here, and so this was originally meant to be a kind of a case study where we discussed with a panel, but the options are really what we would do with any patient. You stage them, you grade their symptoms, and then you see what therapies are available to them within the realm of sanity. And so at 88, and he has clear stage C heart failure. You can go to the next slide. We have advanced options, which I think are kind of off the table. He's not a transplant candidate due to his age. And you're not going to meet almost any 88-year-old who think that they would want to go through an LVAD, or any advanced heart failure doctor who want to do an LVAD in an 88-year-old. He's relatively well for his age, but not overall. I'd call him frail. The second one, which Barry is here, he would support me greatly in this, is cardiac rehab. Kind of get him in a program, see what his exertional capacity is, see if you can get him feeling better just with moving more. Lifestyle changes, so cut out the salt, all the normal stuff we do in heart failure. And then optimizing medications, which for him, there's a few different ways you can do this. And some heart failure doctors kind of disagree on how you should approach these patients. Some say get them on the smallest dose of everything that has a benefit. So Entresto, Spiro, beta blocker, and then SGLT2 inhibitor. Start at the lowest doses and then start going up. Some say do a stepwise approach. Start with one, go up, do another, go up. I probably fall into the camp of start low and then go up on everything slowly, just to see how much you can get on. And then the last is device therapies or valvular interventions if they have valve lesions. This guy had already had a CRTD device. He didn't need an AV node ablation, or an AFib ablation. He had an AV node ablation. Next slide. And so over the next 6 months, his goal-directed medical therapy was up titrated lisinopril to Entresto at a low dose, went up to the middle dose of Entresto, had a slight AKI that resumed within about 1 week with a recheck, or 2 weeks with a recheck that resolved. We switched his Lasix to Bumex because of his refractory edema and his slightly low albumin. We added Farxiga and a very low dose of spironolactone. At the end of the above period, his blood pressure was low for most people, but I kind of like this blood pressure, 90 to 100 over 50 to 60. No falls, severe lightheadedness, dizzy spells, nothing like that. On his device check, he was adequately BIV paced. The question here of thoracic impedance is an interesting one. Do we look at his core view numbers? How helpful is that? And I think that is a little bit of a difficult question to ask because of the studies done in those trials where you look at actual outcomes of does it prevent heart failure hospitalizations? And I think it's kind of difficult to say that it does, but in one sense, it is an early marker that they're becoming decompensated prior to the edema kind of getting worse. And then obviously he had no major valve disease on his echo. His follow-up TTE after his med optimization remained low. At 88, he'd had this for a while. I wasn't expecting him to recover, but he did well for a few months. And then he had recurrent heart failure admission with anasarca requiring BiPAP and then 10 days of IV Lasix. And so the question here for the panel would have been, what do we do next in a patient who's a little bit older who you kind of still want to be aggressive. He had a relatively active lifestyle, and he really wanted to stay out of the hospital, but was clearly failing it despite best attempts to prevent it with what we would do normally. So the next slide. The idea here is clinical inertia, and I don't know when it was officially coined. In the 80s, when insulin was becoming more popular in France, there was a doctor who talked about patients who probably needed insulin, but they were right on that line. And so do you do the more aggressive thing, or do you back off and say kind of more is less in this situation? And that's the concept here. And the next slide talks about the next thing that we did, which is a CardioMEMS device, which is a pressure sensor you implant in a patient's pulmonary artery. This is the schematics of the device. So the device itself is about the size of a paperclip. It has no battery. It's essentially as much risk as a right heart cath, maybe a little bit higher than that. And it goes into kind of the posterior, usually left pulmonary artery of a patient, kind of as close to their back as you can get it. And then what happens is whenever they go home, you get baseline readings, and then they daily send you uploads of those pressure readings using a pillow at home. That pillow uploads their pressures to a website that I then review, and then we decide, okay, your pressures are starting to go up. Let's do an intervention prior to your edema getting worse and prior to being decompensated to the point of needing admission. And so after talking with him and his wife, we decided to pursue this. Next slide. And so this is data from the trial that kind of got this therapy approved. And what you see is a difference in heart failure hospitalizations that kind of diverge somewhere around that 3-month period, where patients with the device who are being followed with data, as you could actually do it as often as you like. They could probably do it 20 times a day if they were OCD, but we asked them to do it at least once a week and hopefully like daily. Where if you see their intracardiac pressure starting to rise, you do an intervention prior to the edema coming. And that process helps prevent a lot of heart failure hospitalizations as documented here. Next slide. And so we referred him for CardioMEMS. One of the fringe benefits of doing a CardioMEMS, especially if they're younger and maybe more of a player in advanced options, is you get right heart cath data at the same time. So his pressures at the time of his CardioMEMS were actually pretty good. His RE pressure was 7. He had a PA diastolic of 12, a wedge pressure of 10, and had a normal cardiac output and index. And so even though his wedge was 10, his PAD was 12, over the course of the kind of roll-in period for the device, we ultimately set a goal of him of 14, because that's kind of where he settled out at over time. And one of the things that's almost an existential crisis with CardioMEMS is we currently follow, I think, 42 patients, and you have that many patients sending you daily data that you need to act upon. And so that can be a little overwhelming. And so one of the things you need to do if you're setting up a CardioMEMS clinic is having very clear guidelines of what do you react to, what do you do if this happens, what do you do if that happens, in a way that doesn't have the physician looking individually at that many patients' daily uploads of their data. And so we have that set up pretty well in our clinic. And so just kind of discussing CardioMEMS, that's an important piece if you're going to do these kind of therapies. Next slide. And so this is the timeline that kind of matters, that kind of makes the argument for why CardioMEMS matters, is that what we would do prior to this is a doctor would evaluate you. They'd look for signs of clinical physical exam signs of heart failure. But by the time you were there, you were so close to decompensation that was like 50-50 if you made an intervention, if you were actually overloaded. And what this data with the PA pressures does is it gives you kind of an extended frame of action where you get about 10 days where if their pressures start to go up and you intervene, you'll literally see their pressures go down. And so it's an important aspect of patients who are difficult to keep out of the hospital, have real heart failure. You've tried everything you could do to do that, and you're still failing as an extra tool that I think is very helpful. And so I think this is my last slide, or one of the last slides. So I followed him the past 18 months. Over that time, despite having 7 heart failure hospitalizations around the 6 months that I first met him, he's had no recurrent heart failure hospitalizations, and we've had 5 actionable pressure changes prompting outpatient diuretic adjustments. And for this patient who takes care of his wife, who has a lot of other health issues, it's a big deal for him. And so I think that this was a good case to kind of pinpoint the different things we can do in heart failure other than just transplant or LVAD. And so I think the last slide is just questions. If anyone had any questions about the two cases or things that you would do different or anything that you guys might have. So currently, and I don't know if Deb is in the room with Abbott, but I think it lacks a national coverage decision. But in New Mexico, it's covered relatively well. So in Medicaid patients, I have almost no problems getting them covered. The indications for that is NYHA3 symptoms with either HFrEF or HFpEF, and either heart failure hospitalization in the past 6 months or an elevated proBNP. And so in those patients, it's pretty easy to get it covered outside of a few situations, both Medicare, Medicaid, and then commercial is even easier. But there's some states where that's not true. Like University of Utah has a very larger, robust heart failure program, and they follow, I think, 3 or 4 patients who are all part of the research trial, GUIDE-HF, and we follow almost 40, I think 42, 44 patients, and it's just because our payer market allows us to do that. And I don't know, that variance is payer market dependent, I would assume.
Well, thank you very much.